Introducing you to people across North Carolina and around the world who put their Catholic faith into action. This is Faith Works on Catholic 540 AM Divine Mercy Radio. Now, here's your host for Faith Works, Ellen White.
Hello, everyone, and welcome to a special edition of Faith Works on Catholic 540 AM Divine Mercy Radio. Our show highlights individuals that put their faith into action every day, amazing people who have an interesting and sometimes overlooked impact on our Catholic faith. On Faith Works, we share their stories. I'm your host, Ellen White. Today I have the pleasure of speaking with Dr. Patrick O'Connell. Dr. O'Connell, a native North Carolinian, earned his undergraduate degree from Brown University and his medical degree from the University of North Carolina, Chapel Hill. Dr. O'Connell trained with the Johns Hopkins Primary Care Internal Medicine track at Johns Hopkins Bayview Medical Center in Baltimore, Maryland. Dr. O'Connell returned to the Raleigh area in 2006, joining Duke Health as a primary care physician, and in 2017 founded Sentinel Primary Care. Dr. O'Connell has a certification in Catholic healthcare ethics from the National Catholic Bioethics Center. Dr. O'Connell is an underwriter of Divine Mercy Radio. Dr. O'Connell, thank you so much for your time today.
My pleasure.
And for this interview, I'd like to have you explain the difference between coronavirus and COVID-19. Have you explain how the virus is transmitted, the symptoms we might expect to experience when the symptoms appear, and then dive into a series of questions from our listening audience. So obviously, information is changing by the second, but as of yesterday, Thursday, of the 2,505 tests completed, there are 136 confirmed cases of COVID-19 reported either by the North Carolina Department of Health and Human Services or by local county health departments in North Carolina. To slow the spread of the illness, North Carolina Governor Roy Cooper has banned mass gatherings of 100 people or more, closed K through 12 public schools, and ordered bars and restaurants to close except for takeout and delivery. Let's start at the beginning. What is coronavirus and what is COVID-19?
Yep. So coronavirus is a nomenclature issue. So coronavirus is a family of viruses. Now, these days, when people talk about coronavirus, what they mean is the coronavirus that emerged out of China during the wintertime. So coronavirus as a virus family, sort of think of it like whales. Well, there's blue whales and right whales and sperm whales and narwhals. So there's lots of subspecies. Now, the recent coronavirus, the nomenclature of it is COVID-19, which is an acronym, Coronavirus Disease 2019 is where that comes from. Okay. So when people these days say coronavirus, that's what they're talking about, and COVID-19 is kind of synonymous, but officially COVID-19 refers to the illness that comes from it.
I see. Okay. What are the symptoms, and do they appear right away?
So the symptoms are kind of those of other respiratory viruses. There's nothing really uniquely distinctive about it, which is part of what makes it challenging. But so things like a cough, a fever, a sore throat, it's a little less likely to cause head cold symptoms than your run-of-the-mill cold virus. But the same things that a run-of-the-mill cold virus could do, or that the influenza could do, are the same sorts of things that coronavirus can do. So it's respiratory viral symptoms. Those are the symptoms of the current coronavirus. How,
as a local physician, do you prepare for something like this?
You mean like when somebody calls me sick, or just in general, how do you prepare for?
Exactly, in general.
So, yeah, I mean, stuff like this is hard to prepare for. It's one of those theoretical concerns that, for years the infectious disease folks will say, oh, we're due for a pandemic. There was the 1918-19 flu pandemic. We're due for something like that again. But, it's like, well, what form is it going to take? What infectious organism is it going to be? You remember 10 or 12 years ago, 12 or 14 years ago, there was West Nile virus, and everybody thought, ooh, maybe this is going to be it. But it didn't turn out to be that severe. In general, some people got bad disease. Ebola virus created a big scare, but it never really got ahead of steam for being transmitted widely. So ones like this it's hard to prepare for it. You respond when it comes. You have some broad brushstrokes of plans in place, but it's hard to say, oh, we're going to know it's going to be this kind of virus, and here's how it's going to be spread, and here's how we're going to be prepared for it.
Well, sticking with this then, as you are treating people locally and you're preparing for this and you're reading about it and it's here, what is your protocol for treating patients? What are you doing?
Yeah, so we've had to really upend how we handle respiratory viruses in the office. It used to be 3 weeks ago, if somebody had a cold, like, yeah, come on in, we'll check it out and see what's going on. Now it's like, if you got a cold, oh my gosh, don't come into the office. Whatever you do, don't go see a doctor. So essentially like my office protocol, what we'll do is if someone is mildly sick, kind of a cold, I'll have a phone visit with them, but I generally don't recommend folks come into the office, both for the sake of the next person who comes into the office so they don't risk infection, for the sake of my staff. But I'll have a phone visit to kind of assess symptoms and try to figure out what to do. If someone were severely sick, I would say go to the emergency room. It's more that middle group of people that are moderately sick. They need to get checked out because maybe this is pneumonia rather than coronavirus, or maybe this is the flu rather than coronavirus. So those are folks where I do have to bring them into the office. So we have a hyper-neurotic protocol in the office for how we get people in. We keep ourselves protected. We're super gowned up and shielded with all this protective equipment. It's things like we give people instructions. When you get to the parking lot, call us, and I will get on the phone with them. I'll take the story. I'll ask the questions they need to ask. We'll figure out what testing we're going to do. And then I'll say, okay, now you can get out of your car and come to the office and knock at the front door. Do not touch the door handle, and we will bring you a mask. And we get all gowned up and give them a mask and bring them into the room, very quickly examine and do whatever testing, whisk them back out, sanitize the whole office after they've left. So it's a major protocol and a major effort just for one person to come in because they got sick.
Have you had any test positive for coronavirus?
Not yet.
Okay. And getting back to symptoms and what people should expect to experience, how is the virus transmitted? What do you?
Yeah, so transmitted the same way that cold viruses are. So respiratory transmission, somebody sneezes next to you, that cloud of droplets that's suspended in the air, if those come in contact with mucosal surfaces, that's how it can spread, which is the same as colds and flu. It also can spread through surface contact. So the person who touches the doorknob, and then you touch the doorknob behind them, and now your hand has the virus, and then you rub your eye, that's the other way that you can get infected.
Okay, and how do we prevent the spread of the virus? Yeah,
so this is where we have turned society upside down. Everybody staying away from everybody else. There's this social distancing, which is such an odd phrase. But the idea is you're supposed to stay far enough away from other people that if they cough or sneeze, you're out of range for their droplets. And then trying to be super mindful of surfaces you might come in contact with, the handle on the cart at the grocery store, the doorknob, the counter at the doctor's office as you're checking in. Trying to be really mindful of those surfaces and then not touching your face, which is impossible advice to give because you can not touch your face if you're thinking of it. Then the moment you're not thinking of it, you touch your face. So anyway.
So let's dive into some of these questions and then, we'll follow up at the end with comments that you might have or recommendations that you might have, if that's okay. So Deirdre in Raleigh asks, can one be a carrier of the virus without ever getting sick? Then she goes on to say, if I have it but do not show symptoms, I'm not sneezing or coughing or expelling droplets, how am I infecting others? Also, if I don't show symptoms but have the virus, when does my body get rid of it?
Yep. So for the first part of the question, can you be a carrier? So the answer is yes. There was, early in the course of this, the cruise ships were a big topic because somebody gets on the cruise ship. It's a closed environment. They sneeze on everybody, and then everybody comes down with coronavirus. So one of the cruise ships that was held in port or held somewhere. They wouldn't let the people off. They tested almost every single person on the ship. And the stats were something like 20% of the people on the ship tested positive. It was about 600 people, 700 people tested positive. Out of them, half were asymptomatic. So half of the people in this sort of serendipitous lab study of what coronavirus does, half the people who were infected had zero symptoms. So the answer then, can you be a carrier? The answer is yeah, absolutely. And the available data would suggest if you get infected, there's only a 50% chance that you're going to have any symptoms from it. Now, then the follow-on question is, am I therefore contagious to other people? Actually, one just sort of backup thing, I was talking a minute ago how the coronavirus family of viruses, it's like whales, there's lots of different subspecies. So that phenomenon of asymptomatic infection has been very clearly documented with other strains of coronavirus that are more kind of your run-of-the-mill cold viruses in people. There's very clear demonstration of people becoming infected. You can detect the virus with nucleic acid testing, and then their immune system gets rid of it, and they never have the first symptom. So that's not a weird thing for the coronaviruses. They don't always make people sick. And with this one, it seems like it's only half the time do they make people sick. Now, so then the follow-up question is, if a person is an asymptomatic but infected individual, can they transmit the virus to other people? The answer there is unresearched. We don't know. Just the phenomenon of asymptomatic infection with the current coronavirus, COVID-19, was just documented with this cruise ship, a few weeks ago or a month ago. So then you'd have to set up another study where you find a cohort of infected asymptomatic people and then test their close contacts and try to isolate, well, did they have contact with other people who might have had it? And so it would be a difficult study that you'd have to do a lot of legwork to prepare the study to set it up. So I don't know that we'll have a practical answer to that question in the interim. But in principle, at least, I would imagine you could spread it to other people, even though you're asymptomatic, which then raises other questions like, well, dang it, if I'm infected and asymptomatic and I could infect other people, well, how do I know if I'm infected? And the answer is, practically speaking, you won't.
You won't know, but maybe just being tested to see if you have it, and then going through.
So then the issue is, well, who do you test? So there have been cases like on this cruise ship where they just tested everybody regardless, but the number of people who would therefore need to be tested in this sort of protocol would be every American. 350 million people, which is wildly impractical. So that's it's like, on the one hand, it's reassuring that if you get infected, 50% chance you have no symptoms, but highly distressing that if you get infected, there's a 50% chance you have no symptoms and maybe could perpetuate the spread of the virus.
Very interesting.
Yeah.
Okay. Jamie in Wake Forest asks, when are more tests likely to become available? I don't know if you'd be aware of that.
Yeah, so this second. So the test availability is ramping up literally day by day.
Okay.
Early on, people were talking about trying to get their hands on hundreds of tests for the state. Literally this morning, so Friday morning, LabCorp announced that they have the capacity to test 20,000 people per day.
And who has access to the tests once they're in the proper hands? Would it be places like LabCorp, doctors' offices, hospitals?
So there's a couple different avenues. So one of them is apparently the health department does some testing, but I tried to figure out how do people get access to that, and I couldn't readily figure it out. But so the state, I think, has a lab that does testing. But the commercial labs have testing. So LabCorp and Quest both have their in-house tests. And then some of the regional healthcare systems have developed their own in-house tests. So I think UNC developed one, or maybe they have developed it and they're applying for FDA stamp of approval. I think Duke has one that they've developed so they can process it in-house. As the couple of weeks have gone by, lots of places have testing that they can turn to. And then the question is actually getting tested. which typically doctors' offices can do it. Some places are setting up like drive-through testing, which I have seen. So like I'm doing testing in my office, for example. So kind of like any other test, like I'm at my doctor's office, got to get a test, and I hand it over to LabCorp at the end of the day, and then they process it from there.
What about results? Quickly?
Yeah. So 3 to 4 days for LabCorp is what they've posted most recently. I saw a report that UNC was able, for hospitalized patients, was able to get test results within 24 hours. That was several days ago, so that could be old news already. And I don't know what their current is, but it's not the lightning fast like rapid strep test or flu swab that you can do in the office where you have results 10 minutes later.
Okay.
It's a several day turnaround typically.
Okay. Moving on to Monica in Raleigh. She states, China has no new cases. It boggles my mind to think isolation, home isolation, wait, and then resume life. How does that look in reality? And how is it that cases don't just start again? How do you see this ending? Or better put, do we expect the disease to start up again once the quarantine is lifted? Dr. O'Connell.
So total wild speculative opinion, I would say the idea that China has no new cases is total baloney. Either the only way you get no new cases is if you stop testing people or you just don't report your results. Because this is a new substrain of the coronavirus family, which means there's 7 billion people in the world who are susceptible to this virus. So the idea that a country of 1 billion people, 1.5 billion, managed to put a 100% stop to transmission seems highly improbable. So yeah, I would be pretty skeptical of that data. Sorry, what was the second half of the question?
So moving on from isolation and then going out.
Oh, right. So, yeah, this kind of gets into the big picture view of what we are attempting in the U.S. and what other countries are attempting, which is isolation in order to slow the spread of the virus. With, I think, a couple of objectives in mind. So the first objective, the one that immediately comes to mind, is slow the spread of the virus so that that subgroup of people who are going to get severely sick, that group gets sick slower so the health system can keep up with their care. As I had sent out an email to practice members and other folks in which I'd said, envision some isolated hospital that has, I think I said 5 ventilators, and 10 people become severely sick at the same time, all of them needing a respirator, then 5 people are in deep trouble because they don't have a respirator or ventilator. So the idea then is if those same 10 people get sick, instead of all at once, they get sick over 5 weeks, 6 weeks. Well, now only a couple people at a time need the ventilator, and so you can keep up. So that's part of the strategy with the attempt to slow the virus. Now, there's a second component to it, which is the hope that maybe warm weather and the virus settles down. Maybe it'll act like a cold virus. Maybe it'll act like flu virus in that regard, and that it just won't be so prevalent in warm weather. I think that's at the level of hope right now rather than any documented experience there. But if you could slow it down enough to where we make it to hot weather and then maybe naturally the rate of infection slows, maybe that gives us some breathing room. But the other side of this whole thing is that if there's 350 million Americans who are susceptible to this virus, it's hard to envision a way of stopping this in its tracks. So I really think, this is just me, my best guess, not an infectious disease expert or an epidemiologist, is I think lots and lots and lots of people are eventually going to get this virus and get sick with it, or get it. 50% of them get sick with it. It's just a question of how fast does it happen.
Okay.
And actually, since I just said something that might alarm listeners, like most of you are going to get coronavirus,
right,
is so 50% of people who get sick, just to reiterate that, have no symptoms based on the cruise ship study. And many of the people who get sick with coronavirus have very mild illness. It's kind of a cold. There's a very small but illustrative study of Italy, maybe? I can't remember where it was. Anyway, somewhere in Europe where somebody got sick, they tested all the family members, and I think like 10 people got sick or 9 people got sick, and most of them had a cold-like illness. It was pretty mild. So there is some hope in that to say, okay, people do clearly get very sick with this virus, but that seems to be, fortunately, a smaller percentage than what the initial data would have indicated. So although I think lots and lots and lots of people will eventually be infected with the current coronavirus, I don't think that lots and lots and lots of people will become deathly ill. I think most of those people will have a mild illness or no detectable illness at all.
Would it be safe to say that those with pre-existing conditions are the ones that seem to suffer the most?
Yeah, that seems to be age and coexisting medical conditions are risk factors for a worse go of it with infection.
And younger children or children don't seem to be. Would that be an accurate statement? This
is very interesting. The statistics from I think it was initially from China, which, again, I take the data with a bit of a grain of salt, but I think other experience has confirmed this, that younger children are at relatively lower risk of symptomatic infection. Which is nice, because so often with the flu, for example, it's folks who are older, folks who have coexisting medical conditions, and they're very young are the ones whose lives are really the most in danger. So it's good to see that at least one of those groups, the young kids, seem not to be in such danger. I mean, there are instances of kids getting very sick, deathly ill, but the frequency among children seems to be lower than it is in other groups within the population.
You touched on the flu, and I think now it would be a good time to discuss that, the comparison between the flu and COVID-19. There have been some that have suggested that this is mass hysteria, media, pushing something that's really not as bad as it seems. And then when you make comparisons to the flus that we experience every year, the mortality rate with the flu versus what we see now, it's really not that bad. How would you...
I have very mixed feelings on this. On the one hand, I realize people are dying of COVID-19. On the other hand, there's part of me that has wondered, is the hysteria? Is it? Anyway, I don't know. I have a bit of misgivings about the unintended consequences that come from the huge societal effort. So because there's a price that you pay when people are out of work, don't have money, can't afford their health care, and can't take care of their diabetes. So there's an unintended consequence that comes. So I worry about that. But that being said, in terms of the connection, or the comparison and contrast to flu, so flu, in some ways, influenza, the flu is kind of boring because it's old news, but it's a substantial illness. The seasonal risk, when you average out good years and bad years, the seasonal risk of coming down with the flu is about 2 to 4%, roughly. So folks will get their colds and sore throats and stuff typically a few times a winter. Flu, 2 to 4% roughly chance per winter. And the stats in America are that on average, and there's ups and downs on this, approximately 35,000, maybe 45,000 Americans die of the flu or its direct complications annually. That's a big number, but it's familiar, so therefore it gets some press attention, but it's not new, and so therefore it doesn't get lots of news attention. So here's the part where we've got a very well-known quantity of the flu and its impact annually, and then a very unknown quantity with COVID-19 and uncertainty about what could happen. So here's a contrast piece. So the approximate mortality rate for influenza is about 0.1%. So about 1 person in 1,000 who gets infected with the flu will die from it, on average. The early data from coronavirus was 2 to 3% of people would die from it. So that's a 20 to 30-fold increase. However, as often happens with new infectious diseases, is early in the course of it, only the sicker people are identified as having the disease, which gives you a skewed sense of severity. So people have speculated, but we don't have the data. People have speculated that maybe the mortality rate for coronavirus is more like 0.5%. Or I saw another person, this is, it's all based on statistical modeling, who speculated maybe 0.2 to 0.3%. So if that turns out to be the case, and then you compare that to the flu, so that would make the case fatality rate 2 to 5 times worse than the flu. So that's bad. It's not Ebola bad, where 75% of people died from it. So, so as I've kind of been thinking of how to categorize coronavirus, I've sort of put it in the category with flu, but a couple rungs up on the ladder in terms of potential severity. Part of the issue, though, is everybody is susceptible to coronavirus, so that's a lot of people, even at a 0.2 to 0.5% mortality rate. That's a lot of people. So that's part of the fear with coronavirus, is that it does become this sweeping infection that is fatal to lots and lots of people. So that's what drives a lot of the effort from a public health standpoint to take such remarkable measures to shut everything down and separate everybody from each other.
Mm-hmm. Mm-hmm. Okay. Patsy in Raleigh asks, why are masks bad to wear if you do not have the virus? And will there be a mandatory corona vaccination? Well, we can move on to the next question after because it's kind of unrelated. So why is there so much information out there about not wearing the mask if you don't have the virus?
I don't know. I think actually early on, I think it was because there was a bad shortage of masks. So the people who really needed them couldn't get them. So I think the early effort was to say, hold on here, save them for people in the emergency room, for example. So, for example, when this started to ramp up and I realized, all right, it's coming to North Carolina. So I went on to I have two medical suppliers that I use. I was barely able to get the simple surgical masks, and I could not get any of the N95 respirators, and I still can't. Mm-hmm. And I've logged on multiple times. Everything's back ordered. Everything's out of stock. Mm-hmm. So, we have a small supply and we're guarding it very carefully. But I think that was some of that initial impetus to say, don't wear a mask, just don't use them up yet because other people need them more. But it's not like there's an inherent problem that a mask is going to cause you if you were wearing one. Mm-hmm. So the only thing I can think of was just to save them for other folks who need them.
Well, would that still be the case then? Don't, because medical professionals need them. So if you don't have the virus, do not get the mask. If you have a mask,
send it to me. If you have an N95, send it to me. Just kidding.
Okay.
So that's a good question, because now that coronavirus is becoming more widespread in the community and asymptomatic infection has been identified and mildly symptomatic infection has been identified, if someone were out in having potential public contact because, hey, I need more milk. My milk is bad. I've drank it all. Then you could make a case to wear a mask when you do that. That seems plausible to me. Now, again, if you're staying outside of 6 feet and all that, that minimizes your risk. Interestingly, one of the other proposed benefits of masks in reducing respiratory viral infection is it's a physical barrier that keeps your fingers away from your face. So that may be part of the benefit as well. Mm-hmm. So in that case, maybe you could wear mittens.
Exactly. Mittens and masks.
Yes.
Be good. A new fashion statement. Will there be a mandatory corona vaccination program in our future?
Who knows? I will say Monday, the first clinical trial started on vaccination. It ain't coming in 2020. It's going to be 2021 before we have a vaccine, assuming that one of these vaccines they're testing works. So I don't know. Who knows what'll happen? Ask again in a year. I don't know.
Okay. And Denise, kind of going back to the flu question, Denise in Raleigh asks, why don't we shut down for the flu each year if it kills far more people?
Yep.
Again.
Yeah, it kind of goes back to the idea that flu is a known quantity. With coronavirus, there's at least the potential that it could be more severe in the numbers of people who get infected and therefore the number of people who die from it. This goes to a knowing that there are undesired, unintended consequences of a shutdown like this on livelihood, mental health if you're holed up in your house and scared, is the effort proportionate to the outcome? That's a judgment of prudence. And unfortunately, we don't have lots of the data that you would want to have to know how well will the effort work and what will the payoff be and how many deaths might be averted. And, we just don't know. So folks are shooting first, asking questions later.
You kind of touched on this, too, people feeling the need to be locked up inside. A couple of questions on that from me personally. So fear and panic seems to be everywhere. And I overheard somebody at the grocery store saying, you should not be out. You need to be at home and not going anywhere. So the question is, it's obviously going to start taking a toll for people that feel that way mentally and getting outside. What do you feel about that? How do you feel about that?
Yeah, I think a couple components. One is some of it depends on a person's risk. So if someone were in poor health, truly their life might be in danger if they were infected, that's somebody who may choose more restrictive self-isolation. Versus somebody who doesn't, let's say, have contact with people, somebody who's healthy, and then if they got infected, wouldn't have contact with people who would be in particular danger themselves. Maybe that's somebody who's less stringent. I think there's a assessment of somebody's risk if they got sick and risk of infection that can guide some of those decisions. The other part of it is what's okay to do? Because clearly there's one level of risk if you are in an elevator with 6 other people versus another risk if you're walking on the greenway and you're the only person on the greenway. So, and any gradation in between that in terms of how much you're potentially exposing yourself to other people. Cabin fever gets old after a while. So some, I would imagine for many people, some judicious amount of physically being outside, particularly if you're respecting 6-foot limits and it's a breezy day that blows the virus away, would probably be extraordinarily low risk. And I'll say, too, just general air in the outdoors is very minimal risk. You can think of it sort of the same way with colds. If the person who lives across the street has a cold and you're sitting on your front porch, there's really no concern there. So I think you could apply the same thing with coronavirus as well.
That's a good point. That's a really good point. We talked about this already, but Emmy in Raleigh asks, are kids still low risk in general? Also, what are the potential long-term consequences for survivors, if any?
Yep. So thus far, yes, kids are still low risk. Not zero risk, but lower risk than other age groups. And long-term consequences, so since we don't have long-term follow-up, not totally known, this is totally extrapolating, so ignore the next 30 seconds if you want. But so if you draw on the experience of people who get very sick, who end up on ventilators, for example, and then you look at other illnesses where people end up on ventilators because of lung disease, there can be some component of scarring to the lungs in those other settings that in theory might apply to somebody who becomes deathly sick with coronavirus. But outside of that sort of extrapolated circumstance, I don't know of any long-term follow-up concerns, but then we also don't have long-term follow-up. So that is a good one to ask again in 6 months.
Exactly. Well, speaking of that, we would like to have you again next week and weekly,
sure,
if we can, and continue to talk about this because there's so many questions that are coming in on this. Do you have anything that you would like to add now at the end of our interview about your feelings or your findings and what you would recommend to our listeners?
Well, one of the things that I've suggested to folks is just because of the disruption that is going on, from a medical standpoint, if a person takes a critically important medication, it's probably worth having a bit of an extra supply on hand so that if there are supply line disruptions, that the person's life isn't in danger because of that. That's not particular to coronavirus, but to the societal implications of it. So that's one thing. The second is, I know there is a high intensity fear that is kind of gripped the entire world at this point, and it's hard to know, how much do I get swept up in it? Because doggone it, this is going to go on for a while. I mean, this, not meaning necessarily all the societal disruption, but this virus, I think, is probably going to be with us for a while. So, there's only so long I can live in a state of high panic before I just get exhausted. So, to take your precautions, figure out what your system is going to be in terms of your activities, and then enjoy some TV and read a good book and pray the rosary. Try to not live at high panic continually, because we may have to settle in for a while of dealing with this virus in one form or another, one impact or another.
Pray the rosary, indeed. Well, touching on that a little bit too, so let me add some comments here. Let me add some information too. The first couple of days when this came out last week, I was glued to various sources for information, and then found that I had to turn it off. I got away from it, and I was not at all interested in listening to anything. That helped me mentally tremendously. But found a couple of resources that I could go to that didn't have a lot of fluff, that just gave me the information that I was looking for, and then I was able to move about my day. Do you have any resources that you would recommend that our listeners go to for accurate information?
Yep. So a good one, the one that I have posted to emails that I sent out to practice members, and I think is a pretty good resource, is the North Carolina Department of Health and Human Services, NCDHHS. I don't know what their web address. It's probably that .org, ncdhhs.org, or just Google North Carolina Department of Health and Human Services. So their kind of landing page for coronavirus actually is well organized and has a lot of good links and a lot of good accessible information without sort of being excessively fear-provoking, without burying you in too much detail. I've actually found it really well designed. So kudos to whoever put that page together. They did a good job with it, and it links to other resources. I like that one a lot, and that's the one that I have suggested for folks.
Oh, fantastic. And it's local, too. That's what I like.
Yep.
Okay. Any final thoughts beyond what you've already shared?
Nothing else I can think of. Check back in the news in 12 hours. I'm sure everything I've just said will be completely wrong, and I'll have new things to say.
Great. Okay. Well, then, until next week, we will be chatting again. In the meantime, where can our listeners go to find you, Dr. O'Connell?
Oh, yeah. So you could Google me, Patrick O'Connell, MD, or my practice, which is sentinelprimarycare.com. And lots of info about the practice there. sentinelprimarycare.com. Listeners, stay well. You're in our prayers. And should you have any questions for Dr. O'Connell for next week's show, please email us at the station at info@catholic540am.org. Again, that's info@catholic540am.org. Thanks for tuning in to our special edition of FaithWorks on Catholic 540 AM Divine Mercy Radio. Our thanks to Dr. O'Connell for visiting with us today. If you missed any part of our program, you can play our past shows by going to catholic540am.org and clicking on local shows. The executive director of Divine Mercy Radio is Cecilia Flannery. Our director of programming is Peter K. O'Connell. Our engineer is Keith Flannery. I'm Ellen White. Thank you for listening, and may God bless you.
Local radio. It's important to you. It's important to our community. While Catholic 540 AM Divine Mercy Radio provides great national Catholic programming from the EWTN Global Catholic Radio Network and the Ave Maria Radio Network, we are also committed to providing local Catholic programming to our listeners across Eastern and Central North Carolina. That's why we produce the local program you're listening to now. If you have any comments on this or any other local programs we broadcast,